Hello, thanks for dropping by. Today we're going to be looking at urinary incontinence. So first, before we begin this discussion, let's talk about some anatomy. So here we're drawing the bladder down to the neck here and continue down to the urethra. So there's two sphincters that I'm drawing here. And the bottom sphincter is going to be here. So let's talk about it. So the top sphincter here is going to be internal sphincter. So the internal sphincter is the one that's actually not under voluntary control. It's controlled automatically by the the sympathetic nervous system. The other sphincter here is called the external sphincter. The external sphincter is actually under conscious control, and this lies within the urogenital diaphragm. Diaphragm. And the biggest muscle, or the most important muscle in the urogenital diaphragm, is going to be the levator ani, which also helps constrict the external sphincter, especially when there's any abdominal contraction. There's also going to be this, you're also going to get contraction in this area onto this external sphincter, and so this prevents any leakage of urine while you're coughing or contracting your abdominal muscles. So next what we'll look at is going to be some of the receptors. So in the actual bladder wall, where you have the detrusor muscle, it's innervated with beta 2 receptors and M3 receptors. And as you already know, beta 2 receptor is sympathetic, and then M3 is going to be parasympathetic. Next here with the internal sphincter, this is going to be alpha 1. And so this is also a sympathetic innervation. And finally with the external sphincter, it's nicotinic, and that's because it's under voluntary control, and so it's going to be skeletal muscle such as a nicotinic receptor. So this is the overall bladder anatomy that's important when discussing incontinence. What's also important is taking a look at spinal, where the actual nerves come from the spine. So here we'll draw a quick spinal column here, and then so this is going to be the medulla oblongata. Okay, 1 second, get this right. Okay, so there you go. And then above that is going to be the pons. So the pons kind of has those fibers running perpendicular there. And so this is the overall important factor. And so what we also put in the spinal cord is the fact that you have the sacral plexus, the sacral area, and the lumbar area. And so what I want to do now is I want to double this image on the right hand side. And so we're going to talk about two situations. One when the bladder is empty, and so we're going to talk about all the physiology related to that. And on the right hand, we're going to talk about when the bladder is full and you want to micturate. So on this side, we can just draw some, so that's some urine going down there into the internal sphincter. So first, let's pay attention to the side where it's empty. So the first thing that's going to happen is you're going to have some sensory root fibers, and these sensory root fibers are generally located in the lower part of the bladder. That's where they're condensed. So what's going to happen is, since there's no urine here, it's going to feed back a decreased impulse via the parasympathetic nerve, and there's going to be decreased stretch fibers firing into the spinal cord. And again, that's all through the parasympathetic cord. And so what tends to happen is, as soon as you get that, that's going to then activate fibers in your lumbar plexus that are related to your sympathetic nervous system. And so from there it goes to the sympathetic chain, which there's a ganglion there, and then that's going to activate the beta 2 receptor via the noradrenaline. So again, what happens is there's decreased stretch fibers that go up to that go into the sacral plexus. They will travel up into the lumbar area, and then through the hypogastric nerve, they're going to release noradrenaline onto the beta 2, and that's going to cause detrusor relaxation. So just to write this here, so it goes by the hypogastric nerve, and that's going to activate beta 2, which causes detrusor relaxation. So you don't get any, leakage of urine there. So, but that's not all that happens. You also get some other fibers activated. So this parasympathetic also activates or inhibits fibers that go all the way up to the pontine. And the reason why it's inhibiting it, it's not necessarily inhibiting it, but the firing rate is really slow. And so then when it goes into the pons, or at the pontine micturition center, This is then going to release other fibers. So one of the first, or I guess one fiber that it tends to release is it's going to go back down into the sacral area here, and it's going to release another parasympathetic fiber to the M3 here. And what it's going to do is going to release acetylcholine and activate, and not activate. So it's going to inhibit the activation of acetylcholine and M3. So, let me see. Okay, so to write this down, the stretch fibers will inhibit micturition center, which will then subsequently inhibit the parasympathetic nervous system output from the sacral area of the spinal cord, and then this will in turn prevent the firing of or decrease the firing of M3, and that will lead to detrusor relaxation as well. So as you can see, there's two ways to relax the detrusor: either activation of the beta 2 for the sympathetic system, or inhibition of the M3 in the parasympathetic system. But that's not all. Actually, there's going to be one more final route here. It's also going to activate. It's going to send another fiber into the sacral area, and it's going to activate the external sphincter via the pudendal nerve. So that is the third fiber there. Is going to be over to the pudendal nerve, which is going to activate the skeletal muscle, which is the external sphincter. So that's going to cause constriction of the external sphincter. And actually, I just realized that I forgot that with the hypogastric nerve, it also sends a signal to the alpha 1. And so let me write here. So the hypogastric nerve here activates the alpha 1 and the beta 2. And so with beta 2, you get detrusor relaxation, and with the alpha 1, you get internal sphincter constriction as well. So the internal sphincter constriction occurs there. So overall, when your bladder is empty, there's two primary things going on. Firstly, you have detrusor relaxation, and secondly, you have the internal and external sphincter constriction. And this is what's going on when your bladder is empty. So, so that kind of sums up when it's empty. Let's kind of look at what happens when it's full. So when it's full, again, you get the same thing. You get, real quick, generally when you're at 300 to 400 milliliters, the parasympathetic fibers start increasing their frequency of firing. So this causes enough stretch so that you can actually get a signal input. And so what you'll begin with is increased stretch fiber receptor firing by the parasympathetic nervous system. And so what this will do is this will actually this time activate the pontine micturition center. So once you get activation of the pontine micturition center, pretty much exactly opposite will occur. So now, so let me write here. So you get activation. So increased firing leads to activation of the pontine micturition center. And so from there, you get activation of the sacral area. So that's going to release parasympathetic fibers into the M3. And so that's going to cause constriction. So the first thing that's going to happen is activation of the parasympathetic, which is M3, which causes detrusor contraction. And next, what will also occur is you get the pontine micturition center will also inhibit the sympathetic fibers in the lumbar area. So when you have inhibition of beta 2, you get, so let's write this down. So the micturition center inhibits sympathetic nervous system, so that's going to decrease beta 2, and again that's going to lead to decreased contraction. So again, via two methods you get detrusor contraction. One is by the parasympathetic activation, and the other one is by sympathetic nervous system activation. And just like before, the sympathetic nervous system also activates the alpha 1 by releasing noradrenaline. And and when you have activation of alpha 1, that's going to lead to you have inhibition of alpha 1, that's going to lead to internal sphincter relaxation. And finally, in order to micturate completely, you have to send an inhibitory signal to the sacral area, and then inhibit the pudendal nerve, and that's going to lead to relaxation of the external sphincter. So in general, what you just need to realize is that there is parasympathetic involvement, sympathetic involvement, and voluntary or somatic nervous system involvement. So all three are involved when you're talking about emptying or filling the bladder. So, so the exact opposite occurs during filling. You have detrusor contraction, and you have internal sphincter and external sphincter relaxation. So relaxation. And again, we can say it's filling. We can also say this is, obviously causes micturition as well. So that deals with the physiology. Now we'll talk about the pathology involved. So we'll begin by the definition of urinary incontinence. So the definition is going to be the involuntary leakage of urine. So that is the simplest definition that can occur. And so let's talk about how can what are the things that can cause involuntary leakage of urine. So again, we kind of have two factors playing here. We have the detrusor muscle on the outside, the two sphincter muscles, and even the levator ani. So the first problem that you can have is too much contraction of the detrusor muscle. And so if you have too much contraction, that can overflow the system here and cause release of urine. But on the other hand, which you might not have also considered, is too much relaxation. Because if you have too much relaxation here, the urine won't flow out, and then so it'll kind of stay in here. That's called overflow incontinence. So if you have too much relaxation, that's overflow incontinence, meaning the urine never leaves. And if you have too much contraction, that's called urge incontinence, where you have the constant urge to urinate. The other issue is going to be if you have a weakness in the internal sphincter. So any problem that prevents the internal sphincter from contracting will obviously also can cause incontinence. And even the urogenital diaphragm, where the levator ani, if there's any type of abnormality there, it can also lead to urinary incontinence. And finally, any of these nerves get cut off, that's definitely another cause. And that could be a cause of either weakness of the detrusor muscle or too much contraction, and it can also be a cause of weakness of the sphincter. So that's overall, I guess, pathophysiology. Let's talk about some causes that are not necessarily chronic causes, but just transient causes. So just temporary causes, you do need to kind of be aware of them, so you can, of course, rule those out first. So there's a nice mnemonic for this. It's called DIAPPERS, diapers with two P's. So we'll kind of go down each one. So the first one is going to be delirium, or acute confusion. So this will be a cause, obviously, because if they kind of don't know what they're doing, they're not aware, even though they need to urinate, they won't urinate, and then they just end up urinating on themselves. So as soon as they become, go out of their phase, or whatever it may be, or the confusion, they will be, urinating like normal. Second one is infections. So we're talking about UTIs here. So anyone with a UTI is at risk of having urinary incontinence. However, as soon as their UTI abates, they should be fine. The next is going to be atrophic vaginitis. So atrophic vaginitis is basically, like the name says, you start having atrophy of the vaginal walls and the bladder and the urethra. And so this is typically the case with older ladies after they go postmenopausal and have low estrogen. And so generally, by providing them with estrogen, they can bounce back, and that'll clear up the problem there. Pharmaceuticals, lots of drugs and causes. We'll go into the different drugs in a little bit. You also have psychological problems such as depression, can also lead to these type of issues. Also, some type of psychological disorders, other psychological disorders can express themselves as this urinary incontinence. Excessive urine, and so what this means is someone who's drinking too much fluids. So someone has polydipsia, like diabetes insipidus, they might have this incontinence. Restricted mobility, so they may have the urge to urinate, but they can't get up and go to the bathroom. And finally, stool impaction. So someone who has very severe constipation and they have stool impaction, that can kind of cause compression on the bladder, and so decrease the compliance of the bladder. So those are transient causes. Let's talk about some drugs real quick that can lead to it. The first is going to be anticholinergics. These are primarily used as antipsychotics. So anticholinergics prevent relaxation of the bladder, so that can definitely lead to incontinence. Also some of the anti-Parkinson drugs, and that includes some anticholinergics, but anti-Parkinson drugs. also can do it. Alpha agonist or antagonist. So remember, the alpha receptors are found in the internal sphincter. So if you have an agonist, it'll contract too long, causing overflow incontinence. And if you have an antagonist, it won't be able to contract, so you can lead to stress incontinence. The other is going to be diuretic and ACE inhibitors. So of course, this is going to increase the amount of frequency of urination, and so that increases urgent incontinence. Calcium channel blockers can prevent the sphincters from contracting, or even maybe the detrusor muscle. And sedatives and hypnotics. So in these situations, the person is unaware of the fact that they need to urinate. So that will eventually lead to incontinence. Now there are some investigations which you do want to perform. So we'll go over the investigations that are general throughout any, I guess, incontinence, and then as we go through specific types of incontinence, we'll talk about more specifically what each one requires. So the first thing is going to be, say you have an emergency room case or a trauma case. One of the first things you want to rule out is either cauda equina or any type of cord compression, because both of these type of spinal injuries can lead to sudden urinary incontinence. And these will require MRI and CT, and this is probably one of the only times you're going to want to do MRI and CT with regards to urinary continence. So whenever you suspect any type of spinal lesions, you want to do MRI and CT. You also might want to do urinalysis and culture, and this will help rule out UTI, which is a transient cause. And with that said, you also might want to do urine cytology to rule out bladder cancer, because I guess that can also cause this as well. Renal function test is also important, because the pathology that's within the bladder might be affecting the renal function, and especially if in the case of cystocele, you want to definitely look at the renal function. Urodynamic studies. These are a few studies you want to do to kind of look at how urination is occurring and whether it's normal. The first one is going to be Euroflow studies, and what this does, it relates the pressure in the bladder to the flow of urine. So you kind of look at those two, and this can help differentiate different types of incontinence, one from the other. The next one is going to be post-voidal residual volume. So this is the amount of urine that's left over after urination, and so this is particularly useful for looking at overflow incontinence. And you can either do this with ultrasound or catheter. So what you can do is you can look at ultrasound, see how much of the bladder is full, or after they're done urinating, you can put a catheter and see how much more urine you can remove. And finally, bladder compliance. So this just means how much the bladder can hold, and what will the pressure be at specific storage capacities. And finally, you can do a cystourethropy, which pretty much just putting a camera through the urethra and into the bladder. Okay, so now let's talk about the different types of incontinence. First, we have stress, urge, overflow, and neuropathic. So these are going to be your fourth one. There is a fifth one. I'll talk about that soon, but these are most of your distinctive ones. So first, what I'll do is we'll look at the different, kind of just overview of how to differentiate each one. So stress is when there's leakage with increased abdominal pressure. And so this increased abdominal pressure can occur when there's a cough or a sneeze. So what the person will classically present with is, every time they sneeze or cough, they have a leakage of urine. Usually very, very minor, nothing too big. The next one is going to be urge. Urge is when they have the patient is going to say that I have a sudden feeling of urgency, and then they try to go to the bathroom, but they fail. So before they can even make it to the bathroom, they end up urinating on themselves. So that's the classic presentation for urge. Overflow means it's due to some type of bladder distension. 1 second here. So here you go. Okay. So it's due to some type of bladder distension. So either they, maybe something wrong with the sphincter, or the bladder is not contracting. So we'll talk about some of the causes when we look at that more specifically. Neuropathic can be either caused by some type of brain, spine, or peripheral nerve lesions. So those three are neuropathic. So now we'll talk more specifically about stress. So there are different causes. First, we'll look at men. So with men, more specifically, the main cause is going to be surgery, specifically TURP. And TURP is transurethral resection of the prostate. And this is when they go through the prostate and they remove out the whole they go through the urethra to remove out pieces of the prostate. If it's and so this can lead to stress because it'll stress incontinence because it'll cause weakness of the sphincters there. In women, however, the causes are a little bit different. The first cause is going to be hypermobility of the sphincter. And so what this means is, so normally if you look, here's the bladder here, and then we have the external sphincter, right? So the external sphincter is within the urogenital diaphragm, more specifically the levator ani. And so what happens is this external sphincter is going to move downwards. And so this is what it's going to look like. So I'll just draw it real quick. What happens when it moves down? So there's your bladder, right? And so here's your levator ani, the urogenital diaphragm. And so what's going to happen is the sphincter is going to be found below the levator ani. And so why this occurs is because of vaginal delivery. So mothers have had a lot of babies, they tend to have this. And so what happens is generally the levator ani contracts with abdominal muscles. So when you cough, you increase the pressure that's on the. So here we go. So when you cough, you tend to increase the pressure on the bladder from the top, and that's all from the abdominal pressure. And so what happens is at the same time, your levator ani is going to contract as well, and that's going to cause constriction of the sphincter, the external sphincter, which will cause constriction of the urethra and prevent the urine from discharging. So now, if you have contraction and the levator ani is above the sphincter, it won't be able to contract the sphincter, and so your external sphincter won't know to contract harder during that moment, and so during that moment the urine will actually leak all the way through. And so that's the general pathophysiology of hypermobility of the sphincter. However, this isn't the only reason. The other problem that can occur is if there's sphincter deficiency, and this sphincter deficiency is usually caused by atrophy of the vagina, and this is usually postmenopausal women. That's generally a cause for them, and if you give them estrogen replacement, they tend to improve. So there are some investigations which are specific to stress incontinence. The first is going to be the pad test. The pad test is you make the patient wear a pad either for 1 hour or 24 hours, and then you measure how much urine they're leaking. Generally what you do is you weigh the pad before and after, and for every gram increase in weight, it probably refers to about 1 milliliter of water. The other is going to be a cough test, and so what you do in a cough test is you fill the bladder up and ask the patient to cough, and as they cough, you look for any discharge of urine, so it's pretty straightforward. The other one is going to be a Q-tip test. Q-tip test primarily checks for hypermobility of the sphincter. And so what you do is you put a Q-tip into the urethra up to the bladder, and then you ask them and you look at the degree at rest, and then you ask them to strain. So maybe you ask them to contract their abdominal muscles or cough. And if the change between rest and strain is more than 30 degrees, then that's diagnostic for hypermobility. If it's less than 30 degrees, then they probably don't have a hypermobile sphincter. Next is going to be urodynamic testing. And that's the kind of testing we talked about before. And generally what you'll see that they have a low urethral pressure. Finally, what kind of treatment options are there? First, we're going to talk about some lifestyle treatment options. This first is due to weight loss, because people with higher weight tend to have more stress incontinence. Changing diet, such as decreasing caffeine and all these things. And Kegel exercises, they strengthen the muscles in the perineum, so that can help decrease stress incontinence. Finally, drugs. There is a specific drug called duloxetine, which is a serotonin noradrenaline reuptake inhibitor, and this can help decrease these symptoms. And surgery. There are some surgical procedures, not really worth going into them, but just know that there are some surgical procedures if all else fails. So that has to do with stress incontinence. Now let's talk about urgent continence. Generally, urgent continence is due to detrusor overactivity or maybe hypersensitivity, which can occur, especially in UTIs. And this needs to be differentiated from an overactive bladder. An overactive bladder is when a patient has urgency, frequency, but they may or may not have urgent continence though. So someone might just be using the bathroom frequently and have a real strong urge, but they never have any form of incontinence. So you need to kind of look into those. And another cause actually for urgent continence can also be decreased bladder compliance. So this might be what this pretty much means is the bladder can't hold enough urine. So maybe as soon as it fills up a little bit, it'll contract, or maybe the bladder is just too small, or something is blocking it from filling up completely. What are the causes? There can be different causes. It's differentiated based on the underlying etiology. So there could be neurogenic causes. So maybe again with the nerves are not are more sensitive, and so even with slight stretch, it'll just start contracting. Myogenic causes, this is the muscles. So sometimes the muscles will just are against hypersensitive, and they'll contract. And you also have urothelial causes, which has to do with the lining. And finally, there's idiopathic causes, which they don't really know why, but the gentleman has, or the gentlewoman has it. So now let's talk about treatments. First type of treatment is called bladder training. And so what you do is in bladder training, you're trying to increase the capacity. And so what you do is, you have them just hold in their urine and try to, distend their bladder as much as possible to get their bladder used to, staying up. And so generally what they have to do is they have to do pelvic muscle training to prevent that, contraction going on. And they also have to do relaxation to try and relax the detrusor muscles and the to from contracting. So there's a few things you can do. There's also different lifestyle things they can do. What they'll do is they have fluid management, so they won't, they'll control how much water they drink and kind of keep themselves in a dehydrated state. There are some dietary changes they can make. Spicy food and citrus foods, they tend to cause increased urination. And there's also some drugs you can give them, specifically oxybutylene, which is an anticholinergic, and intravesical botulinum can also help as well. And so we know botulinum is one of the toxins produced by the botulinum organism, Clostridium organism, and so that can cause relaxation of the muscles. Now, there is the other category, which I promised to tell you about, which is called mixed. And mixed category is when someone has stress and urgent continence. And so they're pretty much, investigations, everything is the same, and treatment depends on which one is worse and, the goals they have. And this is actually the fifth column that is mentioned by, most resources. So there's nothing more to say about it. It's just a mixture of both urge and stress incontinence. So now let's talk about overflow. So first we'll get into the pathogenesis, because what can cause, overflow of the bladder. So the first one is going to be bladder outlet obstruction. This can be due to BPH, any type of neck contraction of the bladder. And if you have a urethral stricture, can cause it. Also, a cystocele can cause, and a cystocele just outpouching, and so then the urine can stick there and it makes it difficult to leave. Even pelvic organ prolapse, more common with ladies. That one is. So so one can be bladder outlet obstruction. The other one can be decreased detrusor contraction, and these can be medications that weaken the muscles generally. It can be to some type of spinal lesion, which decreases the signal going to the detrusor muscle, and even long-standing overdistension. And so what happens is when you have overdistension of the bladder for a really long time, the muscles get distended and they can no longer contract correctly, and so that can also lead to overflow incontinence. There are some investigations which are you do want to do specifically for overflow incontinence. The most specific one is going to be the post-void residual volume. And so again, what they do is after they completely try to empty their bladder, you measure the volume that's remaining in the bladder. And so this can also be done by ultrasound, where you actually look at how much urine is in the bladder remaining, or a catheter, where you remove the urine through the catheter and see how much is there. Now, if someone has less than 50 milliliters, that's normal. But if they have more than 200, that's pretty much diagnostic. And in between is kind of, in the gray area, you're not sure if they have it or not. And of course, even with these patients, you want to do the other urodynamic studies. They can help a lot, and you also might want to do a cystourethropy to look even further. Treatments, it depends on the underlying cause. So if the cause is due to say an obstruction, then what you want to do is relieve the obstruction, and this can either be done by an alpha-1 blocker, or they can perform surgery. And if it's not due to an obstruction, you can do something called chronic intermittent catheterization. And so just every once in a while, you just remove some of the remaining urine through catheter. So and that's if it's due to a non-obstructive cause. So the final cause here is going to be neuropathic, which we already mentioned is due to any type of problem that's originating from either brain, spine, or peripheral nerve. This can be, so different causes can be, more specifically, can be strokes, tumors, and aneurysms. These would be, pretty straightforward. So that's what it causes. You can also think of hemorrhage, and we also know multiple sclerosis can also cause that. Spinal cord lesions, you're primarily going to be looking at caudal equina syndrome, which is when there's compression in the caudal equina area. Now, other issue, what they can cause is, the first thing they cause decreased compliance. So what will happen is, or they can also cause loss of sphincter tone. So in decreased compliance, there's high bladder pressure even at low filling rates, and so this can cause quick leakage of the bladder or emptying of the bladder. And this is most common in meningomyelocele, as well as upper motor neuron lesion. So it's kind of like the bladder is kind of in a constant contracted state, which decreases the amount of urine that can flow into it. And with loss of sphincter tone, this is very common in the any type of sacral injury or caudal equina. And so basically all that's happening is the external sphincter is constantly open, and so as soon as they get any urine pressure increases, it'll just come out. So there are some investigations that you want to do beyond what we mentioned earlier. These are going to be, you want to do a neurological examination of the patient, you're going to want to do urodynamic flow studies, but you also want to do CT, MRI, and electromyography. In CT, MRI, you of course want to do the brain and spinal cord, and electromyography, you want to look at the detrusor muscle and maybe even the sphincters. How do you treat it? Depends on which is the underlying reason. If it's due to decreased compliance, so what you're trying to do is so decreased compliance means that the bladder is in a constant contracted state, so you want to try to loosen it up, and this can be done with, again, with anticholinergics such as oxybutynine. You can also use something more central acting, such as imipramine, and of course you can also use botulinum, which is the toxin that relaxes muscles. However, if it's due to the sphincter, so you have a weak sphincter, what you can do is you can use some type of pessary, and so what the pessary will do is it'll kind of act like a cork, and it'll block the sphincter, and so then, and they can, whenever they want to urinate, they can just remove that cork. So just kind of supporting the sphincter there. So that pretty much wraps up the whole discussion about urinary continence. Hope you learned a lot, and I'll look forward to seeing you in the next video.